start now without any problems. So again, I wish to introduce myself. My name is Dr. Eslam Abdelhamid, and I'm FRCS Glasgow. I'm working here in Riyadh, Saudi Arabia, and it's my honor to present my lecture for today in front of all of you. Today we have a discussion about a small blind zone, and actually I wish that to inform you why did I choose this title specifically when I have done this presentation. When I was working on my making the title, I was looking for not only an attractive one actually, but to cover the main values of our lecture. Blind, but still can guide. The actual meaning that blind is a defective area in the visual field, and guide means that where is the lesion? And this is what can everyone can understand from the title, especially if you can look to the pictures from the right. However, the hidden meaning that I was looking for is blind is a dark zone. It's a dark zone for poor medical knowledge for many medical stuff, actually, not only for ophthalmologists, but for everyone, specifically who is not, his studies was not related to neurologists. And guide was how to improve the awareness, how to improve the awareness of those areas of medicine, how to manage it, and at least how to refer the patient in time before irreversible changes can happen. And this is our adventure for today. We were going to take a small adventure, so please be patient. If you have any questions anytime, don't hesitate, just only type it in a note so we cannot interrupt the lecture or the sharing of the presentation. And at the end, we can make it. Any discussion and any questions? Okay, our case of presentation for today. This is our patient, which female patient 55 years old who came on 20th of July 2019. Her sudden persistent headache was her main complaint, and it was not responding to analgesics. Blurred vision, especially during driving, was the second issue that she's complaining of. If you have this patient in your clinic and he's coming with severe headache, not responding to any kind of analgesics, even for profit, what's your first impression that you have to take and what is your decision? Just I will give you a chance for a few seconds to think. What are you going to do for this patient? What's your impressions? And what are you going to order for this patient? Patient coming with blurred vision during driving, severe headache, not responding to analgesic. Just think about it. This patient, by the way, came first to the neurologist in his clinic after going to many doctors, either for ENT, ophthalmologist, and with no response. Okay, so simply let's giving a chance to cover your curiosity and to checking that first thing that you have to do is checking the visual acuity of the patient to confirm that this blurred vision is not related to a dropped vision or error of refraction. We have to exclude any history of sinusitis or ear problems. Number three, checking for any chronic illness like hypertension or chronic heart disease. Number four, if everything is normal, and this is maybe in this our patient as it's already, so we are going to our workup for this patient. This patient came from the neurologist after she has covered all subspecialties and everything was okay, and even the ophthalmologist missed these patients and referred to our clinic. Now it's our choice to make a visual field, at least to take care about the complaint of the patient who's complaining of blurred vision during driving, specifically at night, because the dark areas or dark objects cannot be seen clearly. And that was the visual field of the patient. It's impressive really to check for this and to checking for the positive results that you can find. Let me give you another few seconds to take an impression about our visual field. Okay, as we see in the visual field here, we can detect that there is an area of reduced sensitivity, which is present in either side on right or left eye. This area mainly in the temporal regions, on the upper part of the temporal region. So we have a bitemporal superior field defect with reduced sensitivity. Do you think that this is may having any spot of light in our brain regarding this lesion, or what is the impression of our diagnosis? I think it starts to be clear now. Let's give you some more clues. This is the hormonal profile of the patient. The patient have 940 milli international unit of liters of prolactin. Does it make any sense for you? Of course, in this case, when we have this lesion, a patient present with hyperprolactinemia, patient present with bitemporal field defect. Third thing that we have to think about is definitely yes, it's an MRI. We have to make an MRI brain to detect for any small lesions which may be present in the pituitary region. Some may asking why you do not do a CT scan or something like that, because we are more specific towards the pituitary gland. Because pituitary gland is the only thing which may increasing the pituitary prolactin secretions like that. So let's go on and to check what is the next that have been found on the MRI brain. Look at these axial and sagittal sections of MRI brain and tell me what's your opinion. Is it clear for everyone? I think let's discuss it. We can see here clearly in either sides, either these small lesions on the suprasellar region, either present in the coronal or in the sagittal or in the axial sections of the brain. We can see that we have an infracellular macroadenoma. Yes, it's macroadenoma, and it's displacing and compressing the chiasma. It's taking even a gadolinium enhancement, which is present clearly in the sagittal section. So this lesion, it's what's called a pituitary macroadenoma. This lesion, what we are looking for today, and causing the problems of the whole problem of the patient. Accordingly, of course, without any delay, a surgical plan was done by the neurosurgeon on 4th of August, these are 2 weeks only after discovering of such a condition. And of course, within these 2 weeks, we can find that there is an irreversible damage has been already found in the visual field. So as early as possible was a decision to be done before any further damage become irreversible. Now, let's start the journey from the start and let's flash back to describe our journey equipment. As we see here, that this is what's called a normal boundaries of the visual field. and this is our weapon which has been used to discover this lesion for today. We have found that the visual field has boundaries and is limited by bony prominences of the face. We can find that the temporal region on both sides is the widest part of the visual field because it does not be limited by any bone prominences. In contrast to the nasal part and the superior part, which is the smallest or the narrowest visual field, which is only 60 degrees because it's limited by the eyebrow and limited by the nasal bridge. Downward 75 degrees inferiorly is the less limited because the the cheek of the face is less prominent. So that's why it's inferiorly located 75 degrees apart from temporary 100 degrees because almost no limitations. How to check it? This is our question. We can using here a manual method, using a confrontation method. And this is from the oldest, which we can using a red pen to check for the color saturations among the whole field. And this should be part of the basic examinations of the visual field, either in neurologist clinic or in ophthalmologist clinic. Why are we using red pen? As we said, that to check for the color saturations among the different parts of the visual field, starting, for example, from the temporal regions towards the nasal side, and either the doctors and the patient should cover the same eye in front of each other and open the same eye. So it gives him a chance to detect any visual field changes which can be found because the patient cannot see the target while the doctor can see it. So it's a subjective test. Let us found another method. This is the most modern one. Here we can find that this is what's called an automatic or what's called a Humphrey automated perimetry. There's different models, different technologies, and regardless of which kind of brand that we are using in our clinic, but the automated one, which is recently discovered to cover the whole technologies, having a different systems, different statistics for different populations, and all are implemented inside this machine, this incredible machine, and it can give us a clue about the visual field in accuracy reach about 97%. So this is our discussion for today regarding the visual field and how can be really specific for examining and diagnosing each patient. What types of visual fields that we are using in our clinic? There's different types, of course, and that's according to the point tested of the visual field. We have what's called 10-2, we have what's called 24-2, and what's called 32. What is the significance of these points? I think that every one of us know perfectly that each point can be, each point here in these numbers can be have a significance. For example, if we are using 10-2, 10-2 from each the number, it seems like a low number. So we are checking the central part of the visual field. And this is really important because it tests a central 10 degrees from the point of fixation. And if we are going to check the central 10 degrees of point of fixation, is our target is the more advanced disease of glaucoma, because in advanced glaucoma, the central part is the latest part to be affected. So 10-2 is the most important to be checked in advanced glaucoma. What's meaning by 2? 2, as we see here from the hemifields, we have two hemifields, one above and one below the midline. So each point is tested twice, once above and once below. So what's called 10-2. So what's called about 24-2, and what is the difference between 24-2, 32, and 10-2? 24 testing about 54 points among the field, and it's from the point of fixations we are testing 24 points here like that. So if we having here from 0 on the midline until 24 here, or if you have 0 from here from the midline towards 30 here, this is what's called 24-22. Let's discuss our scope for today, which is 32. 32, we're checking about 76 points among the test I. We have point density about 6 degrees. So what's meaning the point density? If we're looking here, the distance between each 2 points is 6 degrees, and that's called a 6 degrees of testing. Per area, this is the part which has been non-tested from the central point of fixation towards the first point to be tested, which is 3 degrees from the fixation point. What is this dial? The 30 degrees, as we said, that is from the point of fixation in the central part along the midline until 30 degrees. So this is the point that has been tested. Accordingly, we have now having a whole circumcision of a circle 30 degrees from the midline, 3 degrees from the point of fixation, and 6 degrees, a distance between each area, what's called a point density. Of course, one eye is tested each time, and the other eye is occluded to avoid overlapping of each visual field. So fixation should be steady, and the automated Humphrey perimetry having a very good reliability to check for the fixation point, is it false positive or false negative, before starting the test of each eye. So after we finish the visual field of 32 degrees, what is the lesion? This is the question that we are always asking ourselves. What is the lesion? How can we detect the lesion area? If we can see it, it will be easy, but it's inside in the brain and it's at least a dark zone, we cannot detect the area. How can we detect what is the lesion required? So this depends on the location of our lesion along the visual pathway. As we see here in these pictures, we have starting from the cones until the end of the journey on the occipital cortex. So if we have in here, starting from the cones or retinal photoreceptors, bipolar neurons, ganglion cell axons among the optic nerves to the optic tract, the optic chiasma, then the optic tract, and then what's called a lateral geniculate body, as you see here. And then from the lateral geniculate body, we can detect that optic radiation starting to radiate among the upper and lower optic radiations before it settled in the house of vision of the occipital cortex, what's called a primary visual area. So, do you hear before about a word called congruous? I think most of you knows what's meaning by congruous. Well, congruous means highly accurate, and it's sharply respecting the midline. If you are going more posteriorly towards the occipital lobe, towards the optic radiations, and to the final destination, of course, it will be more congruous because it's morely presented on the occipital cortex. However, if you're starting here in the distal parts, because it's still away from the occipital cortex, we still have many fibers which is decussating or distracting the pictures of the visual field at the end, and that's why what's called non-congruous. So the more posteriorly, the more congruous lesion. So that's meaning about congruous. So now, before we're starting our journey, we have to know what's meant by congruous, how to detect the area of the lesions, or what is our stations that we are going to stop, and what is the visual field. Let's go on and check how can we detect each lesion before we go. But first of all, I'd like to know first what is the lesions. Which lesion can affect our visual pathway and why it affecting it? It depends according to the age, definitely. We have in different causes. We have congenital causes like hydrocephalus or agenesis. We have lesions which may happen in old people like vascular stroke, thrombotic hemorrhage or embolic, diabetes, hypertension, atrial fibrillations, ruptured aneurysm. All of these can affect the coagulopathy of the blood vessels and can lead to further damage to the brain. It may be the inflammatory causes in young age, like in case of demyelinating disease, optic neuritis, which may lead to further vasculitis of the blood vessels supplying the brain. It may be traumatic directly and causing direct damage to the affected part of the visual pathway. It may be autoimmune, like in systemic lupus, or antiphospholipid antibody syndrome, or maybe the dramatical infiltrative changes of neoplastic. And this is the main problem actually, because the neoplastic is the most damageable part or cause, and may cause multiple lesions, and may causing confusion or conflicting what is the exact lesion for this patient, because you have this patient may come in a late presentation and have different signs which cannot detect except if you can check by MRI or CT scan at least. So brain imaging may be helpful in this stage. Let's start first with a most important station in our journey, which is a chiasmal syndrome. I think that chiasmal syndrome is the most important, so we do not start from the optic nerve because we have to discuss the most common and the most late presentations and the most dangerous that we have to detect it earlier in order to prevent any irreversible damage. And this is what's called a chiasmal syndrome. What is a chiasmal syndrome? It's a group of signs and symptoms which may happen as a result of compromising the optic chiasm, whether from below, whether from above, whether from the sides. And this is the optic chiasm here, which we have already seen before on the picture. The optic nerve starting to degasseting to the opposite side to forming the optic tract, and this is what's called an optic chiasm. There's many causes which may lead to optic chiasmal damage. And according to Wadud et al. In 2014, we have found that the pituitary adenoma is the most common cause to damage to the optic chiasm. It accounts about 58%, and it happens as a result of damage or a lesion here below the optic chiasm and causing compression over the chiasm. Other causes, it may be craniopharyngioma, which is maybe from the above the optic chiasm from here and cause damage to the optic chiasm here. It's about 20%. While the third cause is meningioma, and this is from sphenoidal ridge, which may be present about 8%. Other causes, which is rarely happens and causing chiasmal syndromes, is multiple sclerosis, neurofibromatosis, and internal carotid artery aneurysm. What's the most common symptoms of chiasmal syndrome? This is our questions. The patient, although in early cases this patient may come completely asymptomatic, and these patients may present with blurred of vision only 54.8, or what's called 55% only present with blurred vision. Not everyone coming with blurred vision. And retaining of the color vision, retaining of the visual acuity is common. However, in order to these symptoms to happen in the form of diplopia, in the form of headache, in the form of color desaturation, or even blurred vision, very low. And in such cases, this patient unfortunately present with advanced stage of presentation. Of course, additional compression, mechanical compression and inflammation of the adjacent structures may lead to atrophy of the descending optic nerve fibers. It may lead to affection of the cranial nerve passing through the cranial sinus, cavernous sinus. That's why the diplopia happen. That's why headache happens due to increased intraocular tension. That's why color vision and blurred vision will be present because of the compression of the optic nerve fibers and the other cranial nerve. It may be leading to stretching even of these cranial nerves, and diplopia may be present. If we're looking for the signs of chiasmal syndromes, we can find that both atrophy of the optic disc present due to why? Why is this compression of the casseting nasal fibers in the chiasma? The casseting nasal fibers in the chiasma will lead to both eye atrophy, of course. And let's check first, how can we detect the casseting nerve fibers? Let's look here to the fundus pictures of these nerve fibers. As we see here, this is the decasseting papillomacular bundles. And this is the part that's responsible for what's called a bow tie atrophy. As these fibers is mainly presented in the decasseting nasal fibers in the chiasma here, that's why these lesions here will lead to what's called a bow tie atrophy. Is it clear? Let's repeat it again. Here in the optic chiasma, which is a decasseting nasal fibers, it's the main presenters of what's called a papillomacular bundles and nasal fibers. This fibers here is meeting on the either side of the temporal and nasal sides of the optic disc. And whenever this fibers is affected in the chiasma, these fibers will be affected here and reflected as what's called a bow tie atrophy. I think it's clear now. Of course, there is a characteristic visual field defect, what we have said about bitemporal hemianopia, and we have discussed about also as a result of characteristic field defect, there will be involuntary seesaw nystagmus. Why this nystagmus happens? This is an involuntary nystagmus as a trial to reduce the defected visual field. So that's why a brain tried to reduce the field defect. He tried to look or search for a vision. So that's why this involuntary seesaw nystagmus, like someone is confused or lost and is trying to find out what is the picture, what is the vision. And this is what's done by our brain, and it will be involuntary. Let's go now more deeply about what is important in visual field defects. Of course, this is what we have said before, it's a visual field defect in the form of bitemporal hemianopia. But is that all? Definitely not. It may be lower temporal field defect, yes. It may be upper temporal field defect, yes. It may be bitemporal field defect, yes also. So why? Why every lesions can happen as a result of this? Let's check and know more. This is the fibers in the chiasma. Normally, the fibers in the chiasma do not decussate straight. So if we see here that the optic chiasma here, and the fibers coming from the optic nerve towards the optic tract of the opposite side, this is what's not happen. On the right side, this is not happen. This is on the left side what happened. Some of the fibers here form what's called anterior knee of Willebrand. The fibers of the gussating fiber from the optic nerve on the left side making like a herniations anteriorly and low in the right side before it can decussate to the opposite side, and what's called anterior knee of Willebrand. These fibers decussate low and anteriorly and become more close towards the pituitary gland here, in the opposite to the craniopharyngioma, which is located in the upper part. So lesion in the craniopharyngioma will not affect directly the anterior knee of Willebrand, while the lesion in the pituitary gland will affect it directly. And it's reflected, of course, as a mirror image, low and anterior into upper and temporal field defect, because the upper nasal fibers is affected more in craniopharyngioma, so lower temporal field defect will be affected. So simply again, we have two common lesions, as we said, the most common causes of chiasmal syndromes. We have craniopharyngioma or pituitary adenoma. Pituitary adenoma is arising from pituitary gland, which is located inferiorly, so it can compress the lower and the anterior fibers, and the compressing the anterior knee of Willebrand are more, while craniopharyngioma, which is located in the upper part, so it's affecting mainly high and posterior fibers, forming what's called upper nasal fibers, into form lower temporal field defect, because it's a mirror image of the visual field. So we have two lesions, one which is upper temporal field defect, more commonly with pituitary adenoma, and one which is lower temporal field defect, and which is common with craniopharyngioma. I think it's clear now. Is that all? Still, we have absolutely another changes. Not everyone is the same in our population, unfortunately. So there is anatomical variations. 80% of our populations will have what we have discussed now. It's only 80%. While there is still 20% which is varying from the normal population. It's about 10% what's called a post-fixed, so the chiasma is a little bit displaced posteriorly. So that's why the mostly affected lesions will be optic nerve rather than the chiasma, or what's called a prefixed, which is a little bit displaced anteriorly. So the mostly affected site will be the optic tract. So not every chiasmal syndromes will be present by a temporal field defect. Not every one. It depends according to the variations of anatomical variations of the chiasma. Although 80% are present like that, but however, we have still 10% we can be present with prefixed lesions, or 10% which can be present with post-fixed chiasma. So what will happen if the patient have prefixed or post-fixed chiasma? If the patient present with central fixated chiasma like a normal population, which is accounting about 80%, it will happen as a result of the chiasma lies centrally over the cell lateral, so the pituitary tumors will expand directly to the chiasma and causing what's called a bitemporal field defect. Bitemporal field defect. What about if the patient is a prefixed lesions, where is the most of the parts lies anterior over the tuberculum silly? So the optic tumors here will affect more the optic tract, like in the picture here on the right side. Most part will be affected the optic tract. So this patient will be present mainly as a homonymous hemianopia. As we see here, it's a homonymous hemianopia on the opposite side. Why it's not whole line? Why it's not covering the whole lines of homonymous midline completely? Half of the field have been affected. Because we have discussed previously that congruous lesion is affected in this area. This area is not congruous, it's an optic chiasma, so it's still in the distal part of the visual pathway, so the lesion will be incongruous, and that's why the field effect is not completely sharply demarcating the midline. It's just only, like we saw in the middle picture, in which only part of the visual field has been affected. What about post-fixed? Is optic chiasma is displaced posteriorly, so the optic nerve will be first damaged, and the optic nerve, it is damaged, it will appear as complete blindness. Of course, you are cutting the electricity over this eye, but what about the other eye? Why is this junctional scotoma present here? So the junctional scotoma can happen as a result of affection of the optic nerve of the same side and the anterior knee of Willebrand of the opposite side. So that's why the patient present with junctional scotoma. This patient will be present the same like a patient who's present with meningioma. Meningioma, a lesion from arising from sphenoidal ridge, pressing over the optic nerve, it will compressing the fibers of the optic nerve, but not alone. It will take with it the neighbor, which is the anterior knee of Willebrand, causing what's called junctional scotoma. Upper temporal field defect happens as a result of affection of lower nasal fibers, which is crossing to the opposite side in the anterior knee of Willebrand. So we have three other variants. Actually, we have now 5 variants. One is upper temporal field defect, by upper temporal field defect, by lower temporal field defect, or complete by temporal field defect, or in the form of homonymous hemianopia, incongruous, or in the form of complete blindness with junctional scotoma. This is a different visual field change which may happen in chiasmal syndrome. Is that all? Definitely not. We still have another sign this patient is coming with. The chiasmal syndrome is a big story. It's not only limited only by temporal field defect. The patient is present with post-fixation blindness. What's meaning? All of us heard about this term before. Post-fixation blindness. What's meaning by post-fixation blindness? Let's discuss it more in details. We see here in this picture that this is the two eyes. The visual field of the two eyes are overlapped with each other. Part of the intact nasal visual fields are overlapped together, so the visual field will be limited by the part on the central part. The temporal part will be affected, definitely, because this patient has bitemporal hemianopia. Again, let's discuss it again. We have a patient present with bitemporal field defect due to chiasmal syndrome. So each temporal part of the visual field of the right side and left side will not be able to see, while the nasal part has been reduced. Why reduced? Because the two visual field has been overlapped. So it will be the result of complete blindness behind the fixation. This patient can see the central part and the peripheral part cannot see at all. And that's what's called post-fixation blindness. It's more commonly with a proximal or a proximity object. If you can see a near object in front of your eyes, of course the peripheral field will not be seen because of the temporal field effect, and the result what's called post-fixation blindness. Is that clear now? Let's go to another slide for the same signs of chiasmal syndrome, what's called Hemifield slide phenomena. Hemifield slide phenomena, I've heard many of our candidates, our colleagues who does not know what's meant by Hemifield slide phenomena. Okay, let's discuss it in more details. If you see the pictures upstairs, which is in the upper part, which is present 100,000 pounds, or 100,000 euro. What will happen to these pictures? These pictures, normally, it should be either in the form of like that, two eyes, and the central part is affected, or like that, which is two pictures have been away from each other, or like that with hyperdeviations. Why does that happen? Okay, let's discuss it in more details. This patient is reporting a binocular diplopia. As we see that 100,000 euro is not the same like aligned in the pictures above. It may be overlapped together, so one of the zero has been missed or omitted, or it may be departed from each other, so 100,000 is away from each other. It may be hyperdeviations, a part is up and a part is down. Why does it happen? Because this patient has present with binocular diplopia. It's due to inability to stabilize and diffuse the visual hemifields. This patient has a heteronymous visual field defect. This patient has a field defect in each eye, and this is not homonymous. This is heteronymous, bitemporal. And this is a mirror image, so the right side is not the same like the left side. So as a result, the two fields, the patient is trying to fixate, but he cannot fixate or cannot stabilize the visual field, cannot fuse the vision because he has two hemifield defect which is different to each other. As a result, these patients will be present with binocular diplopia because the patient, almost all of us have what's called phoria. The phoria is ability of the brain to control and to fuse the vision together, and this phoria will be manifested as tropia whenever there is marked other factors, multifactorial factors, which may cause further instability of the visual field and cause what is manifested here like hyperdeviation, isodeviations, or exodeviations. So the two fields of the right and left are sliding together either above and down or either right and left. So this is what's called a hemifield slide phenomenon. Again, let's simplify more for everyone who cannot understand it. Everyone in the populations almost have what's called phoria. And what's called phoria means that we are able to control our diplopia by brain fusion of the visual fields. What will happen if this phoria has been changed or manifested into tropia? That can happen, of course, in cases of multifactors, either due to neurological lesions, like our patient who's present with heterogeneous visual field defect. Heterogeneous visual field defect, as the two field defects are not the similar, so the brain is confused. He cannot fuse the two visual fields. As a result, this patient will be present with a field defect, which is this patient who is present with a squint or what's called atropia. This is what's called a chiasmal syndrome. I hope that you enjoy it. We have patients who's present with hemifield. This patient hemifield slide. Patient may be present with a post-fixation blindness, may be present with a color desaturation, may be present with diplopia, may be present with nystagmus. This patient may be present with blurred vision in advanced stage, or may be present with different visual field effect, upper temporal field effect, lower temporal field effect, present with a homonymous hemianopia due to post-fixed chiasmal syndrome, or may be present with a complete blindness with junctional scotoma in prefixed chiasmal syndrome. This is our first stations. Hopefully that you enjoyed it. Let's go now to other visual field defects. We have in other visual field defects lesion affecting the optic nerve, lesion affecting the optic tract, lesion affecting the lateral geniculate body, lesion affecting the optic radiations, or lesion affecting the occipital lobe. These are the different stations of today. Let's go now for more stations. What will happen if lesion affecting the optic nerve? To be broadly minded, let's know what is the difference between the glaucomatous damage of the optic nerve and neurological damage of the optic nerve. Glaucomatous damage usually happens as a result of optic nerve cupping, as a result of compression of the fibers of the optic nerve while it's coming from different parts of the retina. So the increased intraocular pressure will compress the fibers and causing what's called cupping. And main fibers affected will be directly presented on the visual field as peripheral field defect, while the central field is retained until late stage to be present with tubular field. Advanced glaucoma, it will lead to complete blindness, of course, due to a complete optic atrophy. The difference happens with neurological, which happen as a result of neurological lesions affecting the optic nerve starting from the axons coming out from the globe towards the brain, and these fibers will be mainly affected in the central field rather than the peripheral field in glaucoma. It may be in the form of centrocecal scotoma, it may be in the form of enlarged blind spot, it may be altitudinal field defect, it may be seen like that in the form of archdescotoma with altitudinal field defect and bearing of the blind spot. So mainly the difference between the neurological lesion and glaucomatous damage that this is central and glaucoma is peripheral. The neurological lesion is mainly respecting the midline, the glaucoma does not respecting the midline. So let's go on and go deeper to know how is the optic nerve lesion, or more specific, a neurological optic nerve lesion will happen. In optic nerve damage, it depends upon the locations. Definitely yes. So if the damage is near to the globe, what's called distal optic nerve damage, or if the lesion is close to the chiasma, which is called proximal optic nerve damage. Different causes, as we said before, may be due to trauma, maybe due to ischemia, it may be due to autoimmune disease like demyelinating nerve fibers, or even due to optic atrophy due to neurological or hereditary factors. So let's differentiate between when we can say this is proximal or this is distal. If the damage happened to the proximal part, which is away from the globe or near to the optic canal or more near to the chiasma, of course it will lead to ipsilateral blindness as we see in this picture. But the difference between the distal and the proximal is that the proximal will be associated with contralateral hemianopia. Why contralateral hemianopia will be present? Because simply, as we said before, what's called a junctional scotoma. Yes, because the anterior knee of Willebrand will be affected also. So what's called a contralateral hemianopia will be present here also. So this is the difference between the proximal optic nerve lesion, which is present with a contralateral hemianopia, or a distal optic nerve region, which is not present with contralateral hemianopia, because the fibers here of anterior knee of Willebrand will be intact. So other questions. Why the knee reflex is intact in both sides? Why in optic nerves the knee reflex will be intact? Because simply it depends on the afferent fiber from both eyes. The knee reflex is dependent on the both eyes. The awareness of proximity of both eyes is the first order neurons of the knee reflex. So that's why one eye is correct or accurate or intact and the other eye is not. That's why knee reflex will be intact if only one eye is affected. On the opposite, why the light reflex will be affected? Because the light reflex, it depends on the fibers or the first order neurons of the fibers coming from one eye only. So the direct light reflex and the indirect light reflex will be affected in case of optic nerve lesion, while the knee reflex will be intact because the other eye is still working. So knee reflex will be intact. I think it's clear now. So let's summarize optic nerve lesion. If it is close to the globe, complete blindness with normal other side, If it is away from the globe towards the optic chiasma, also the anterior knee of Willebrand will be affected and would be present with contralateral hemianopia. And that's what we see here in this picture. A patient present with right optic nerve lesion in the proximal part close to the anterior knee of Willebrand or close to the chiasma, complete loss of vision in this eye, and on the other side, contralateral hemianopia, because junctional scotoma affecting of the anterior knee of Willebrand. Let's go more deeper. Of course, the chiasma we have discussed in detail, so we will pass the chiasma and go directly with our train towards the optic tract. What will happen in the optic tract? As we said before, that the optic tract is a cylindrical fibers coming from the chiasma, passing backwards and end laterally in the lateral geniculate bodies. This is what's called a lateral geniculate bodies and is located here in the level of the midbrain. What will happen here? Let's discuss it. We said before that the fibers of the temporal sides will run on the same side, while the fiber from the nasal side will decussate in the chiasma to be opposite side here. So the optic tract will carry ipsilateral temporal fibers and contralateral nasal fibers. And accordingly, this is a characteristic visual field change during damage. Let's go deeper and to check what will happen. Lesion of the optic nerve will lead to what's called hemianopia. I think it's time to describe more medical terms about what's meaning by hemianopia. Anopia means complete visual field defect. Hemianopia means a part of the visual field has a defect. What's called homonymous? Homonymous means typical or harmonic defect on both sides. So if the right side has been affected, the right side will be affected also on the visual field on both sides. But what's called of heteronymous hemianopia? Heteronymous is a different, non-harmonic. So if the right side on the right side affected, the left side will be affected. So this is not the same. It's another side. Although it seems similar on the image, but each eye, this is the right side affected, this is left side affected. So this is what's called heteronymous. While the homonymous means it's like moving together, harmonic. So right side here, it will be right side here. And that's what's called a homonymous hemianopia. So a lesion in the optic tract will cause what's called a contralateral homonymous hemianopia, unequal light reflex, or what's called Marcus gum pupil, because of the affection of the pupillary fibers, which is crossing here in the optic tract before leaving, the pupillary fibers leaving here before it decussate or synapse in the lateral geniculate body. So whenever the fibers of pupillary fiber decussate out, this is what's called unequal light reflex or Marcus gum pupil. But behind this area, if a lesion behind the area of pupillary fibers getting out, the pupillary light reflex will be definitely intact because the pupillary fibers is intact. So according to the site of the lesion, is it proximal on the optic tract here close to the lateral geniculate body, or it is distal towards the chiasma, and this will be the affection of the pupillary fibers. So a patient present with an optic tract lesion, this patient is present with contralateral homonymous hemianopia. Contralateral means that if the right optic tract is affected, it will be expressed as left homonymous hemianopia, the patient present with left nasal fiber affection and right temporal fiber affection. This is what's called a contralateral homonymous hemianopia. In addition to pupillary fiber defect, which as a result of optic tract is carrying the pupillary fibers until the end in the distal part towards the proximal part of the lateral geniculate body, while lost pupillary fibers here because getting out toward its pathway of the direct light reflex, here it will be intact. I think it's clear. Let's go to a lesion in the lateral geniculate body. Lateral geniculate body, as we said, let's again to review. A lateral geniculate body is an olive shape. It's located in the level of the midbrain. This area is a synapse of the optic tract of this side and start to form what's called an optic radiations of this lateral geniculate body. Here there is no pupillary fiber because the pupillary fibers already get out from it before it synapses here, so it does not contain any pupillary fibers. I think that you know now, or at least you guess, what will be the visual field defect or visual field change that may happen as a result of damage to the lateral geniculate body. This patient will be present with homonymous hemianopia, the same exactly as the optic tract lesions, but the pupillary reflex will be normal because the pupillary fibers have been getting out from this damage. While there will be an optic disc pallor, still there is some pressure over the optic, descending optic nerve fibers here until it's still close to the eye. Lateral geniculate body is still close to the eye, so damage here in the lateral geniculate body, damage here in the optic tract, damage here in the chiasma, damage here in the optic nerve, all can be expressed as an image for us as optic atrophy. So the disc will be pallor, while damage behind the lateral geniculate body with the starting optic radiations, at this stage the fiber is away from the globe. At that time you may find that the optic disc is completely normal. Let's go into another more deep area. Our next patient is lesion of the upper optic radiation. Optic radiations, as we see here, is what's called a geniculocalcarine pathway. Why it's called geniculocalcarine pathway? Because it's starting from lateral geniculate body and end at the calcarine sulcus of the occipital cortex. There is two lobes, one superiorly, what's called an upper, and what is inferiorly, what's called an lower. The upper called or superior called Barham's lobe, and the lower called Mayer's lobe. As we see in the pictures, this is the upper part, what's called a Barham's lobe, and this is the lower radiations, what's called a Barham's lobe. Mayer's lobe here is close to the parietal or within the parietal lobe. The Barham's lobe is superiorly, he is close to the parietal lobe, while the Mayer's lobe is located inferior towards the temporal lobe. Of course, it's now guessed by everyone that each lobe have the sensitive location, sensitive sensors, and sensitive skills. So affection of these radiations will be accompanied by another lesions. And this is our, how can we guide us where is the lesion? It depends according to other symptoms, other characteristic signs, which may be present with the field defect. Let's go deep and check it. This is what's called in British idioms or idiomatic language, pie in the sky. What's meant by pie in the sky? Pie in the sky means that something that cannot be reached, something cannot be attained. It's like a slice of pie or pizza which is present in the upper in the sky. Let's go up with your eye until you reach to the maximum. It's pie in the sky. We cannot reach it. This is what's called unattainable. So that's why the upper temporal field defect, which may be present, or quadrant canopia, as we said, like a slice of pie, what's called a pie in the sky. And that's what's our lesion of the lower optic radiation. We said before again that's like a mirror image. Lesion of the lower part or lower optic radiation will be reflected on the visual field as upper visual field defect, upper visual field defect, while the lesion in the upper optic radiations will be reflected as lower visual field defect. So that's why in lower optic radiation lesions, which present in Mayer's lobe, or what's the fibers that we said previously, crossing in the lower part of the optic radiation toward the temporal lobe. So here, this patient, now we can guess what can be present with. Present with contralateral, of course, because of the damage of every part of neurological beak to the opposite side. It will be also pie in the sky, because what's called the lower fibers affected, upper temporal field defect, or what's called superior quadrant canopia, or pie in the sky. What else? This patient will be present with other temporal lobe lesions. This patient may be present with difficulty understanding what's called a receptive aphasia, complex hallucination in the smell, in the sound, in the vision, in the memory. This patient have problems in reading areas, so it's called receptive. The patient present with vernix aphasia, and this is all due to inability to understand what's written, inability to understand what's drawn, and this is the function of the temporal lobe. Of course, this patient also is present with auditory hallucinations as a result of affections of the auditory functions or auditory centers that present in the temporal lobe. But the main defect will be in the form of difficulty understanding, to be easy for you, difficulty to understand what's written or even what's here. So it's called vernix aphasia, dyslexia, complex hallucinations, together, of course, with visual field damage, which is contralateral superior quadrant anomaly. What about lesion of the upper optic radiations? Lesion of the upper optic radiations will be present as the following. Of course, as we said, contralateral, we present with pi in the floor. This is the opposite. This patient is present with inferior quadrant anobia. And of course, the patient present with a parietal lobe lesion. We said before that parietal lobe is passing through the parietal lobe. So let's forming what's the parietal lobe lesion? What is the parietal lobe function? It will lead to difficulty performing. This patient cannot write. This patient cannot forming a picture. This patient cannot design. This patient cannot forming a small toy. This patient present with hemisensory loss, of course, because the sensation is the main function which is present in the motor function, which is present also in the parietal lobe. So this patient hemisensory loss, this patient is present with hemiplegia, this patient may be present with agraphia, he cannot draw, apraxia, he cannot form a complex movement or a design, asymmetry of what's called optokinetic nystagmus. What is the optokinetic nystagmus? This is what's called an optokinetic nystagmus. Normally, any person can able to do what's called a normal optokinetic nystagmus. If you are looking to a drum, rotating drum, your eye will moving toward the point of fixation, then fastly, when he missed the fixation point, he returned back to the other side. Look here, the drum is rotating, the eye is following, and then when the drum starting the object to be hidden with the rotating drum, his eye returned back to the point of fixation to again follow the drum. What will happen in case of parietal lobe lesion? It will lead to what's called asymmetry optokinetic nystagmus. If you are rotating the drum like that here, one side will be normal. If we opposite the drum to the opposite side, the lesion on this affected side will be erratic. It will be irregular. It will be suddenly moving, then nystagmus and moving or stopping of the eye. No following of the object like in the normal optokinetic nystagmus. And that's called asymmetry of optokinetic nystagmus. So simply, lesion of the upper optic radiations will be, as we said, contralateral visual field defect in the form of inferior quadrant anobia, and of course, which is more common, difficulty performing. Patient cannot draw. Patient cannot agraphia. Patient cannot do complex movement. Apraxia. Patient cannot feel because the sensory center is present in the parietal lobe. Hemisensory loss. This patient present with motor function defect. Hemiplegia. Patient present with asymmetry of optokinetic nystagmus, as we see in the animations. So we have a patient present with contralateral inferior quadrant anobia. We have a patient who's present with superior quadrant anobia contralateral. Patient present with difficulty performing. Patient present with difficulty understanding. The difference between the upper and the lower optic radiation lesion. Let's go to the final destinations. Now let's go to the final destination of our journey, which is the house of vision. This is the occipital lobe. The occipital lobe is called the house of vision because the primary function of it is the visual interpretation. As we know that, of course, the occipital lobe is located in the occipital bone of the skull. Why the vision is affected? Let's go on and check how the vision will be affected in a patient present with a visual field defect. This is what you are going to look here. Normally or anatomically, this is the lesion of the occipital cortex. If we look to the picture on the right side here in the graph, we have what's called a calcarine sulcus. A calcarine sulcus. Above and below the calcarine sulcus is located or presented the upper quadrant of the macula, the lower quadrant of the macula, and the periphery here, the upper peripheral quadrant of the retina, and the lower peripheral part of the retina. I think that everyone, when he reads this information in the book, will become confused. Simply, the calcarine sulcus, above it is the upper part of the retina, below it is the lower part of the retina. Above it, on the tip of the, close to the tip of the calcarine sulcus, is the upper quadrant of the macula toward the distal part, what's called upper peripheral part of the retina. Let's go down, which close to the tip of the calcarine sulcus, lower part of the macula, and lower peripheral part is called to the distal part. This is simply what we are going to discuss about. Where is the periphery? Where is the macula located? Macula located at the tip. Where is the periphery located? Toward the end of the calcarine sulcus. This is what we are going to check here. Simply, if the lesion affecting the occipital tip, the macula will be affected. So it will be in the form of macular field defect. If the lesion affecting the distal part towards the distal part of the calcarine sulcus, it will be present with either lower temporal field defect or upper temporal field defect. Why the macula will be spared here? This is the question. Where is this area? Why this area is spared? This is our questions. Let's go and describe it in more details. The macula is not affected in this picture because the macula has what's called a double blood supply. And this is maybe a mercury from God. He's just only protecting the macula by double blood supply, one from the posterior cerebral artery and one from the middle cerebral artery. So the macula, if the lesion or stroke affecting one of these territories, this occipital lobe is damaged due to stroke affecting the posterior cerebral artery, for example, the middle cerebral artery still giving a nutrition to the macula. It's supplying it, so the macula is intact. So in stroke, there's still macular sparing. When the macula will be affected, it means that this is an advanced lesion, this complete infiltrative lesion affecting this area. And to happen as a result of, for example, compressive lesions, for example, infiltrative neoplastic lesions, for example, trauma or accident, all of this will affect it. Well, let's go on to a coagulopathy, for example, like stroke, like an embolus, like a thrombus, like in a case of autoimmune disease. It will affecting the macula? Definitely not, because this patient would be really have poor luck to affecting the macula or to affecting the blood supply of posterior cerebral artery and middle cerebral artery. So most of the patients who's coming with occipital cortex lesion due to a stroke, this patient will be present with macular sparing. That's why we have a patient who's present with either in the form of upper temporal field defect, which has happened as a result of lesion of the lower peripheral quadrant of the retina or lower part of the calcarine sulcus, or in the form of lower temporal field defect or lower quadrantanopia due to lesion affecting the upper part of the calcarine sulcus, or in the form of lesion affecting the occipital tip but not a stroke, it will be present with macular area affection, or maybe confusing with the whole other visual field. Like we said before, that a neoplastic or infiltrative lesion will cause damage here to the tip, damage here to the calcarine sulcus, and damage even to the optic radiation. And this patient may be present with even auditory or visual hallucinations, may be present with difficulty performing complex movement. So that's why the patient may be present with complex signs and symptoms. And in this area only, all our rules will be affected, and we cannot judge where is exactly the location of the lesion. But if we are going to follow the rules, either the occipital tube will be affected only, either the calcarine sulcus will be affected only, either the optic radiations will be affected only, or either to be other parts of the temporal and parietal lobe or the ganglion, lateral geniculate body, or other parts as we said before. So let's go on and check what other signs that may be present with occipital cortex. Patient present with visual field change in the form of upper or lower quadrantanopia, contralateral of course, and macular sparing or macula only affected. Let's check what's present also. This is what's called a cortical blindness. The cortical blindness is a patient who's present with complete loss of visual sensation and vision. This patient actually cannot see. However, this patient denying that he cannot see. You will ask him, can you see? Yes, I can see. And this is what's called Anton Babinski syndrome. This patient can see. No, he cannot see, but he denies that he cannot see. because this patient has what's called a visual hallucinations. He can see objects in front of his eye which is not real. This is fake objects. That's what's called visual hallucinations. Why visual hallucination happens? Because of lack of visual fixation and tracking. The object is moving. The sensations over the occipital cortex or presentation over the occipital cortex is not accurate. So this lacking of visual fixation and tracking. Accordingly, this patient may be present also with what's called a redox phenomenon. What is redox phenomena? Redox phenomena that the patient can only see the object if it's moving, but he cannot see the object if it's just only stationary on your table. For example, if you have a pencil or a pen on the table, he cannot see it. Just start to move it. Yes, I can see it now. This is what's called redox phenomenon. So we have is simply patient present with occipital lobe cortex either due to stroke or due to any other lesions affecting, as we said before, having what's called a quadrantanopia, either upper or lower according to the location, with macular sparing or affection of the macula alone. Central field defect may be present with cortical blindness in the form of denial of the visual symptoms, what's called Anton-Babinski syndrome, hallucinations and lacking of fixations, together with redox phenomena, which is inability to see a static object. He can see only moving objects. Of course, the macular sparing, as we said previously, because the vision in the fovea is spared from the blindness because of the double blood supply. So to summarize what we have said today, to be simplified for everyone, because I know that many information in just only one lecture will be very hard, but it's our target for today. We want to take a journey from the start to the end, and we want you to know how can differentiate between different lesions. We have, as we saw before, complete blindness, optic tract lesion, complete blindness in the distal part of the optic nerve or in the proximal part of the optic nerve close to the optic chiasma, complete blindness, and also contralateral homonymous hemianopia. Optic chiasma, upper temporal field defect or lower temporal field defect according to is it craniopharyngioma or pituitary adenoma, or may be present with both if the lesion is advancing, or it may be associated according to anatomical variations. Optic tract, it may be in the form of contralateral homonymous hemianopia with pupillary fiber affection. So that's why light reflex will be not intact. Lateral geniculate body, this patient present with contralateral homonymous hemianopia with pupillary fibers intact. Upper optic radiations, this patient present with pie in the floor and called lower quadrantanopia with other symptoms like in case of hemisensory loss or difficulty performing objects like agraphia or apraxia. Lower optic radiation affection will be present with upper quadrantanopia or pie in the sky, or associated also with temporal lobe lesion, auditory hallucinations, difficulty understanding, receptive aphasia. Occipital lobe lesion will lead to present with contralateral congruous, of course, because this is the most congruous area, homonymous hemianopia, and present with occipital macular sparing because the macula is supplied by double blood supply, so it's protected here. So the macula will be spared. So what is our message for the day? This is a silent disease. Why it's a silent disease? Because it's late presentation. It's not uncommon to be presented late. Most of the patients does not being aware of the signs of field defect. What else? It's irreversible. Unfortunately, damage to the nerve fibers cannot be recovered. So whenever it happens, no way to return back. So rescuing of these patients as much as we can, as earlier as we can, is our target. This is legally blind patient. So these patients, we should be counseled about driving license. It's completely prohibited. This patient cannot drive anymore. This patient is a guide for us. From it, we can know what is the lesion. From it, we can stop the progression even of the disease. So, ladies and gentlemen, this is our final destination, but hopefully that we continue. We wish that our online lectures every day is done in a perfect manner, and our academy will always continue to give you a fresh information every day. We should continue journey for continuous learning. I completely invite and encourage every student, every colleague, every professor to make further lectures. So thank you and wish that our lecture for today was the best and that my message has been delivered to everyone. Please be helpful for everyone, and if you have even a very small idea, I greatly encourage to show the inside talent. Thank you. So now let's start. I wish that to know some, if any one of you have any questions, just raise his hand. I will give him the mic and to discuss it. If you have any questions, just raise your hand so I can give you the mic and to ask any questions if you wish. No questions? Hopefully that this means that you understand our lecture for today completely. Okay, so everyone, thank you for attendance for today. I wish that you have enjoyed our lectures. See you later for further lectures. Thank you.